Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. Today's episode features Beth Faiman, nurse practitioner at the Cleveland Clinic Taussig Cancer Institute. She will be discussing clinical insights relevant to the diagnosis and initial management of patients with multiple myeloma. This episode is part of a larger educational program titled Navigating the Increasingly Complex Therapeutic Landscape in Contemporary Myeloma Care. For more information on our presenter, along with a link to the complete program, including downloadable slide sets, please visit the show notes for this episode. Now let's get started and hear what Dr. Faiman has to say.
Thank you so much for your introduction, and I am so thankful for all of you who've tuned in today to hear about caring for newly diagnosed patients with multiple myeloma. So, multiple myeloma is a cancer of the bone marrow plasma cells. Normal plasma cells are responsible for creating antibodies, the Y-shaped immunoglobulins that are intended to protect us from getting sick. Unfortunately, the most mature of the plasma cells will create abnormal overproduction of one clone of a protein. In 2021, we expect 34,920 new cases with about 12,400 deaths, with a median age of diagnosis at 69 years of age and a 5-year relative survival of 54%. Now, that being said, the time frame in which we captured this, because it takes a long time to capture data, is from 2010 to 2016. Now it's 2021, and I'm hopeful that we'll have an increase in survival reflected when we have another analysis. So what are the common tests that are obtained at diagnosis and throughout for monitoring? I say there's a buffet of options for blood tests, but it really comes down to the complete blood count to look for any elevated, low aberrations in the white cells, red cells, and platelets. We want to look at the chemistry panel, assess for hypercalcemia, renal insufficiency. You take a serum protein electrophoresis to identify the abnormal clones which are present, especially on the monoclonal protein analysis. And then finally, the urine protein electrophoresis will look for the abnormal clones of protein as well. And just like with any other malignancy, a tissue sample is required. What's really important in 2021 is the FISH and cytogenetic testing. We'll talk about the abnormal clones that we need to target and maybe change treatment based on those clones, as well as identifying the clonal bone marrow plasma cell percentage. And because IgM, IgA, IgG, especially with IgM, you can have a lymphoplasmacytic lymphoma, where you'd want to check a mid-88 status and that would be more of a Waldenstrom's. But IgA and IgG tend to behave like multiple myeloma. In terms of radiologic imaging, a whole body low-dose CT scan is recommended by the International Myeloma Working Group. Some centers and practices will prefer a PET scan, whole body PET scan. If you have suspected lesions, an MRI or a CAT scan of that suspicious area, as well as a bone survey. Now, bone surveys are less sensitive, but depending on the state you live in and where you practice, that could be a first inexpensive rough screen to find out if there's any osteolytic lesions present. So in terms of a differential diagnosis for multiple myeloma, I explain it to my patients in 3 phases. So MGUS, monoclonal gammopathy of unknown significance, occurs when a patient has a low M protein, less than 3 grams per deciliter, low clonal bone marrow plasma cell percentage, and essentially no symptoms of the disease. The second phase of somebody, typically with IgG or IgA or kappa or lambda free light chain types of myeloma, will have a higher M protein and still lack that CRAB criteria. CRAB stands for hypercalcemia, renal insufficiency, anemia, or bone disease. The SLIM was added in 2014 to really tease out those individuals with high-risk myeloma who are likely to need treatment. So individual will have active myeloma if they have myeloma-defining events, and you only really need one of the SLIM CRAB criteria features. Now, a point of contention in 2021 is when we start treating individuals with myeloma. The International Myeloma Working Group last year presented this 2020 model, which risk stratifies those with smoldering myeloma. So the IMWG and researchers looked at those who had low, intermediate, and high-risk smoldering myeloma. and taking into account a high M spike, high serum free light chain ratio of capital lambda, and a higher bone marrow clonal plasma cell percentage. The 2-year risk of percentage increased with those who had 2 to 3 risk factors. And this would be the type of group of patients that you would recommend for a well-designed clinical trial. There are numerous phase 3 clinical trials out there trying to identify the best treatment regimen for those who don't quite have CRAB or myeloma-defining events, but might have a higher risk of progressing to active myeloma. The idea is, why wait till somebody has renal failure, hypercalcemia, damage to bone? What's the window of opportunity to start treatment sooner to decrease morbidity? So the revised international staging system takes into account the serum beta-2 microglobulin, which is a nonspecific marker of inflammation, but in a meta-analysis of patients in the early 2000s, it was found to be a high-risk prognostic finding. In the revised staging, we also, however, have a serum LDH, so higher LDH is higher risk, and it also captures the translocation 414, 1416, or deletion of 17p. What's not in here is gain of 1q, which is now found to be a poor prognosticator. As I mentioned before, we do not, across the board, even though there are phase 3 randomized clinical trials that show there could be an advantage to earlier treatment, we still are recommending the context of the clinical trial because there is no gold standard treatment yet. So finding patients who are willing to participate in a clinical trial, if they have some of those 2020 characteristics, is recommended. Now let's change gears towards what are the current treatment landscape for multiple myeloma in general for 10, 20 years. And we only had a handful of drugs available. And now we have all these classes of drugs that can be used mostly in newly diagnosed myeloma and some in relapsed disease as well. Immunomodulatory drugs, corticosteroids, and proteasome inhibitors are the backbone of initial therapy in combination. It's important to keep in mind supportive care throughout. I think we've advanced one's lifespan by recommending bone modifying agents to all individuals with multiple myeloma. Antivirals such as acyclovir and valacyclovir for anybody with monoclonal antibodies or proteasome inhibitors, and then palliative care. Some of the things we would take into consideration when finding that first best therapy: increased age, lower performance status, concurrent comorbidities such as cardiac, renal, or lung disease. We also want to take into account the biology of the tumor. Does that individual have amplification of 1q, translocation 414, 1416, etc.? And then we want to think about the types of toxicity, risk of myelosuppression, infections, etc. What's the cost, administration, and then finally the regimen. A triplet is preferred. We want to treat to maximum response and continue suppression of that malignant clone because of the risk of clonal evolution, which will be discussed later. So in terms of the treatment considerations for transplant ineligible patients, again, using a 3 to 4 drug regimen for fit patients, little frail, maybe dose reduced, a 3-drug combination. We have VRD Light, which is a regimen with low dose lenalidomide, low dose bortezomib, and lower dose dexamethasone, which is very, very well tolerated in our elderly population with very few treatment discontinuations. I sometimes, with really super frail people, will start with just a proteasome inhibitor and dexamethasone in low weekly doses and layer on an IMiD if their performance status improves, as sometimes is the case. Cardiac dysfunction, we want to kind of avoid carfilzomib, especially up front, and then use it cautiously if we need to down the road. And then in terms of peripheral neuropathy, subQ bortezomib and possibly induction with ixazomib Lendex based on phase 3 clinical trial data. I already highlighted the VRD Light, which I love to give to the elderly individuals, especially with standard risk genetics. The Maya study with daratumumab Lendex versus Lendex alone. The Clarion study with carfilzomib melphalan versus bortezomib melphalan, and tourmaline, as we mentioned, the ixazomib Lendex versus Lendex. The SWOG 777 study was one that I participated in. It was VRD versus RD. the V was stopped after 8 cycles, and I still have patients that are on cycle 131 and 140 who participated in that study. So it is something to consider in transplant ineligible. Just again, underscoring the 3 versus 2 drug regimen, and you could modify the doses, but the overall goal is to maximize the duration of the initial response. In patients with transplant eligible, we learned recently that in patients who have high-risk genetics might benefit more from adding carfilzomib to the Lendex versus just bortezomib. The Forte study is a very well-designed study with numerous arms, KRD stem cell transplant versus KCD versus KRD12, and then there was a second randomization for maintenance showing very deep MRD negative rates, again, 10 to the -5 or 10 to the -6, finding 1 in a million plasma cell clones in the bone marrow. Cassiopeia, Griffin, and the IFM Dana-Farber study with the VRD transplant versus VRD arm. Again, all demonstrating extremely high rates of MRD negativity with these 3-4 drug regimens, adding transplant in. So if you're a younger, more fit person, be more aggressive. Deeper responses can translate to an improved progression-free survival, hopefully keeping in remission longer, suppressing malignant clones as well. So in conclusion, induction therapy for patients with multiple myeloma, 3 drugs are better than 2 drugs, but are 4 drugs better? Again, it depends on the genetics, how fit the patient is, what the patient desires are, do they have to work full time, etc. Some strategies for shared decision-making should be incorporated, such as patient preference and a frank discussion about clinical trial benefits, especially supportive care is very important as well.
Thank you very much, Dr. Faiman, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, Navigating the Increasingly Complex Therapeutic Landscape in Contemporary Myeloma Care, please click on the link in the show notes. As always, thanks for listening.